very late isolating and insulating the vulnerable people, especially the elderly in Canada.
Instead of having arrows on the floor of a grocery store, we could invest in improving ventilation and filtration of indoor settings to try and reduce transmission.
We're not going to end the pandemic. All we can do is achieve some form of healthcare strain containment.
From the Zoomerplex in historic Liberty Village, the Zoomer with Marissa Lennox.
Welcome to the Zoomer. I'm Marissa Lennox. Pandemic or endemic, two positions that get to the core of a debate that was bubbling even before Omicron sparked a global infection surge. At what point does the world move on from the pandemic? And even if there is a case for saying the worst is over, what does endemic really mean? But first, we start with the Freedom Convoy that traveled from BC to Ottawa to protest COVID vaccine mandates for truckers and other restrictions. What legacy lies ahead for the movement? We'll discuss. But before we dive in, let's tee up the topic.
In just over a month, the most infectious COVID-19 variant to date, Omicron, has gone from one case to more than 99% of all coronavirus cases in Canada. But an infection isn't what it once was. The vast majority of us are vaccinated, while over a third of Canadians are boosted. Meanwhile, the virus has mutated to its mildest version yet. The risk of hospitalization or death is 55% lower in Omicron cases than Delta cases, according to a new Ontario study. Still, there are more than 4 times the number of active cases now than during the peak of the second and third waves. So, with more and more people catching the virus, what does it mean for the long game of COVID-19?
All right, so much to talk about today. Thank you to everyone for coming on. I do really appreciate it. Now that the dust has settled, Dr. Stahl, I'll start with you. How would you describe the Freedom Convoy that brought thousands of truckers and their supporters to the Capitol to protest mandates? Was it a success? Was it a failure? Your thoughts?
Well, I think that depends on who you are. I think first and foremost, and I hope all the other guests would recognize this, we saw many things that happened during the Freedom Convoy that, particularly in Ottawa, that were reprehensible. The use of swastikas, the use of Confederate flags, the desecration of the Tomb of the Unknown Soldier, the defacement of Terry Fox's statue, food stolen from the homeless. So there were certainly a lot of deplorable events. And I think today, 5 days later, or we're on to the 6th day now, the point has been made by this small group of truckers. We know that over 90% are vaccinated, and the people in Ottawa are still having their lives disrupted in a very substantial way, including the disruption of schools and even vaccine clinics that had been closed. So, I think the point has been made and has been heard, and it's time to allow the people of Ottawa to live their lives, but also to call out some of the reprehensible things that happened over the last few days.
Okay, and to play devil's advocate, no one, of course, is going to defend someone dancing on the Tomb of the Unknown Soldier or worse, carrying a Nazi flag. But is it too easy to sort of tar and feather everybody because of the misbehavior of a group of people? Conrad.
No, it is not fair, and I haven't studied it that closely, but from what I understand, there have been no arrests, no violence. There was one Confederate flag, and the person carrying it was seen off. I don't know anything about swastikas. As far as I know, these people are astonishingly well behaved, given the standards of groups gathering like that and demonstrating in different countries. Obviously, the incidents referred to are outrageous, but I think you're quite right in what you said, that it is not fair to tar the whole group of them with that. And the real issue, as I understand it, is the application of vaccination rules to these truckers. And they simply can't quarantine for 2 weeks when they come back from the United States, which they do, most of them, all the time. And so they have a legitimate complaint. But with that said, obviously you can't have the streets of the capital of the country clogged like this indefinitely. So it's certainly time to ease them out. But I mean, I would have thought it would have been fine to meet with a representative group of them or something like that. They shouldn't just be disparaged as a cover for a bunch of extremists. And the Prime Minister's comment that they may have been racist and misogynist is just nonsense.
But I think we're not asking the deeper question. The elephant sitting in the room is, what do vaccine mandates really achieve at this stage of the pandemic if we are really moving towards an endemic status? Vaccine mandates might get younger adults to get the vaccine, but those are not the people we most worry about straining the healthcare system lest they contract COVID-19. So it's not like we're going to nursing homes and making sure we go from 95 to 100% or 90 to 100%. We're going after a group that is not likely to strain the healthcare system. And then we now have emerging information that vaccines don't stop transmission. So vaccines are a seatbelt or an airbag that prevents someone from going through the windshield if they're at risk of really bad disease, but they are not a collision prevention system. So the debate we have to have is, why do we keep going with vaccine mandates and pushing the point on a small group of people who you're not going to be able to convince anyways, rather than focusing on this egregious group, who we associate with the alt-right? I think we're smearing the group and forgetting the discussion.
It's a fair point, Dr. Stoll. The convoy did start in response to this federal vaccine mandate for truckers, but 2 years into a pandemic. Why now, when we know that there's rampant COVID outbreaks on both sides of the border, and up until this point, they have been exempt? Is this about public health? Is this about equality? And why should there be an exemption for them? What say you?
So I think, as everyone has alluded to this far, this speaks to sort of what we are going to do in terms of pandemic control. And we can get into the term that has been raised here of endemicity, which I would argue has been grossly misunderstood and misapplied across multiple different individuals. And there's also a lack of agreement about what it really means amongst the people who are using it. That being said, we need to face the realities that we have in this country. And the realities in this country, and we have to look forward, are that we have a limited healthcare capacity in our country. And we have seen time and time again that a small group of unvaccinated individuals can overwhelm our healthcare system. And there are complaints about, why do we have such small healthcare capacity? What do we need to improve that? But we cannot tolerate the amount of illness amongst a smaller unvaccinated group of individuals that other jurisdictions are simply able to do so. And that doesn't even speak to the morality of doing that and thinking about who the people are that may be impacted, let alone the unvaccinated, but some of the individuals who are vaccinated and are vulnerable. The easiest way to end restrictions and to move on with our life is to get as many people vaccinated as possible.
That's where I don't agree. I don't think we can end it, Dr. Stoll. I mean, I wish we could. I'm on the same side as you, but the problem is that we have a moving target. We have a moving goalpost, and I think we all see changing science. I was one of the people saying, hey, we had something like the measles vaccine 1 year ago. We thought that. We know it's not the measles vaccine. It doesn't provide what's called sterilizing immunity. It doesn't stop transmission. We have the moving goalposts of the variants. That was a wild card that started. So you have an ever moving target. It's more like influenza. And even if we go to 99% from 95% or from 90 to 95%, we're not going to end the pandemic. All we can do is achieve some form of healthcare strain containment.
All right, we'll have to leave it there. Coming up, has Omicron triggered a shift from pandemic to endemic, or is it too soon to say? We'll get into it next.
A disease can be both endemic and widespread and deadly.
Welcome back. Countries internationally, including Britain, Denmark, Spain, Thailand, and others, are laying the groundwork to treat the next infection surge not as an emergency, but one that is more like how we treat the flu. The shift comes even as the World Health Organization cautioned against assuming the pandemic has reached its endgame. So where does Canada fall? Let's ask the panel. First of all, I think it would be prudent to even define the term endemic. Dr. Stoll, as you mentioned before, it's often a broad and misunderstood term. What does endemic mean? What does it look like?
From a purely epidemiological perspective, it would be where the rate of people that are becoming, if you thought about it like a bathtub, the amount of people who are becoming infected and then moving out in terms of the susceptible phase is broadly equal. So that being said, we have many diseases which are endemic. For example, malaria, which are still widespread and deadly. So that's a confused sort of thing, that a disease can be both endemic and widespread and deadly. Malaria, for example, is endemic. It killed 500,000 people in 2020. Tuberculosis is also endemic. It killed over 1 million people in 2020. So we need to, it doesn't mean that it's harmless, and it doesn't mean that it's not a threat to us. It just means that we have a static phase in terms of case growth that we don't have in the phase of a pandemic.
Aditi, you've spent your career studying pandemics. What does it look like? What does the end game of a pandemic look like?
So the nature of a pandemic really determines how it will go. So in this case, though, the 1918 flu is going to be the most important case study that we can do. And we know by 1920s, it had sort of gone. And by gone, I mean, as it was said earlier, that it will never fully go away, but the infections we get are milder and milder, and then you have what it's like a regular flu. So there is no evidence that suggests that, oh, in 1920, this vanished. Absolutely not. In fact, that's the nature of every pandemic, that it sort of happens, unless you really know something like cholera. Cholera is such a unique case where contaminated water, once you have the data, you clean up, it goes away. We know that it gets milder. There is no evidence of, people might celebrate in the 1920s to have this boom of it's gone, but it probably got milder. There is absolutely no historical research in that field. We didn't even know what caused it. So at that point of time, of course.
Are we there yet, Dr. Rao? Have we reached that state of endemicity? And it's possible you and Dr. Stahl may disagree on this point, but are we at a point where there's enough immunity at the population level, through vaccination, through natural infection, that we can officially change from that state of pandemic to endemic?
Well, the quick answer I'd give is that one place that doesn't have endemicity yet is Australia. They are still facing a full blast. In fact, my favorite disease to compare with, we've had a few now thrown around, would probably be influenza. And the old exam question used to be, how do you define a pandemic? The first part of it is having a strain that is new, that this fits. The other one is having a lack of population immunity. And the third thing is having widespread severe disease. So something like norovirus, it changes every year, but it doesn't cause severe disease, but there's a lack of population immunity and you get big waves. We don't speak of pandemics of norovirus. In the case of influenza, when it was H1N1, we had a lack of population immunity, and we had huge population attack rates akin to what we just saw with Omicron. But we also saw some very significant disease, a lot of younger people ending up in ICU, unlike COVID-19, which seems to affect more older people, bringing them to ICU. With Omicron, we saw a huge attack rate, a lot of disease, but not so much severity, but not puts you to very little severity. It was sort of in the middle. I think we have now reached a phase where we're very close to endemicity in places that are on wave 4 or 5, but places like New Zealand and Australia, having held it back through various border measures and restrictions of travel, have to pay up now. You either pay it up front or you pay later. The other issue is if we go to an endemic phase, it's time to think about the negative consequences or unintended consequences of restrictions, and looking at where some relaxation of restrictions can allow for other things to go on, whether or not case counts rise again.
The original target vaccination rate that was called for, Conrad, was, if you recall, 75% of people over 12 to be fully vaccinated, and 80% with at least one dose. Today, 90% of the population in Canada, 12 and older, is fully vaccinated. 82%, I think, 5 and older, crushing our original target. Well, some might call that crushing our original target. Meanwhile, over 50, close to 50% are triple vaxxed. Canada, there's no question, is a leader in the world in its share of national populations vaccinated, and yet we have some of the toughest restrictions in the world. What say you?
Well, I've always opposed the level of restrictions we've had in almost all the Western countries. As I understand it, basically for people under 65 who were healthy, the survival rate was 99.5%. And even for those less fortunately placed, it was about 95%. We were very late isolating and insulating the vulnerable people, especially the elderly. And Canada does not have a good record comparatively or in absolute terms on the fatalities we experienced in the older population, the group that I'm in myself. But I think the whole business of vaccinating children 6 months old or up to under 12 years old is nonsense. There's no reason to do it. And in my opinion, we have, look, I'm not medically lettered, and I'm not going to debate with those who are on this panel about what constitutes endemic and that kind of thing. But as I understand it, the widespread incidence of Omicron is a very good immunizer. And the very high rate of vaccination, which we were late to come to, by the way. For a long time, we were not in the top 50 countries in that regard, but we are there now. That combination, in my opinion, entirely justifies a much more open policy than what we're doing. And in my opinion, we should essentially follow the British model and, just abandon all of these mandates and shutdowns.
I would agree with Dr. Rao that I think since Delta, sterilizing immunity, and you could argue whether it was ever a realistic possibility, is not the goal here. The goal is really to protect from serious illness and death, and relatedly to protect our health system in this. And so, when you talk about things like protecting the vulnerable population, this shielding approach or strategy has been tried. And it was tried here in Ontario to try and balance the economy and build a so-called iron ring around long-term care homes. And when you have something as transmissible as Omicron or even as earlier variants, it will find and hunt the vulnerable individuals. So this is not simply, the ability to segregate a certain part of the population, and we can again speak about the ethics and morals of that and be able to protect them. We have seen that simply does not work.
All right, stay right there. We'll be back after this break with more of the Zoomer.
Our percentages of casualties in the homes for the elderly and amongst the elderly are scandalous, and they're quite bad competitively.
Welcome back to the Zoomer. Ontario's top doctor, Kieran Moore, said recently we have to start to learn to live with the virus and that we've let our lives be controlled for the last 2 years in a significant amount of fear. His comments come as politicians and the scientific community grapple with whether or not it's time to adopt a learn to live with it approach. And this, I think, really does cut to the heart of the debate, Dr. Rao. Is it time to move on, or should we be cautious about surrendering too soon, or maybe it's more nuanced than that?
So, let it rip completely? No, not necessarily. But I think when it comes to the community, especially when you're dealing with people at lower risk, I think we have to accept that it will spread. Maybe the Omicron is done, but let's assume there's another variant coming, that those variants might well spread. So, mask mandates in the community, we know the evidence is weak, but mask use in a hospital or long-term care, the benefits may be greater. So you can stratify where you're going to relax. I give an example. You go into a restaurant, you put on the mask to come in, you sit down and you take it off and you start eating. Why bother doing that? Maybe the front-facing staff who are seeing you can do it, but if they're vaccinated as well, and if they're double or triple vaccinated, or they've seen Omicron, or they're unvaccinated and they've seen Omicron, I think at that point, there's not much benefit to the masking, for example, and even the physical distancing. We know this disease is spread in an aerosol fashion, airborne-like fashion. So why have arrows on the floors of grocery stores and having people go down one aisle versus the other? It still is in the air anyway. So I do think we can peel away some of these community restrictions. We can also move to a philosophy where we say, if you're at risk, you stay away. Or if you're at risk, you can wear a mask, or you can even wear an N95 mask if it makes you feel better. But let others do what they wish to do, which is leading a more normal life. And also the travel restrictions have to stop as well, and travel screening and testing, because we have a homegrown problem now. We're not keeping anything out with travel restrictions or testing.
I actually agree with everything that Dr. Rao has said there. We need to be honest with people about what we're dealing with here. And, some of the stuff we're doing is hygiene theater at this point, and has not, updated with the mode of transmission. I think what we can do moving forward there are some things that are not restrictive or do not substantially impose on people's lives. Like instead of having arrows on the floor of a grocery store, we could invest in improving ventilation and filtration of indoor settings to try and reduce transmission. I think the travel restrictions are also nonsensical at this point in terms of keeping out disease. I think the one wicked problem, though, that all of this doesn't confront is the fact that we do have this limited healthcare system capacity. And as a result of the restrictions, not just to the community and the way we live our lives, but to the care of other people who have had cancer surgeries and diagnostic procedures and other medical care delayed, we still have a large unvaccinated population. And those individuals, even in their 40s and 50s, and I was just up in the intensive care unit at my hospital this morning, there are people in that age group who are ventilated, who are in ICU beds, who are critically ill with COVID-19. Those people are still going to pose a threat to the stability of our healthcare system, which at baseline runs at or above capacity, especially during the winter months. And that is a wicked problem that we need to be able to confront, and comes back to the, what we talked about maximizing vaccination levels, because many of the measures that Dr. Rao is talking about in terms of reducing transmission are less relevant now, now that many of us are fully or triply vaccinated and we are protected from severe and critical illness.
On the one hand, Conrad, you have the risks associated with disease, which include being sick and hospital overcrowding, which is what Dr. Stahl was most recently talking about. On the other hand, you have the sort of unintended consequences of social interventions. And as a society, I think we've pretty much collectively decided that the former has greater importance, but now, or at least had greater importance, but now that the disease is milder, does that change this equation? And at what point do we start taking seriously the consequences of that social intervention? How do you balance those two paths?
Well, I agree that it's difficult to balance them. I also agree with everything my friend Dr. Rao said. I think we should look at this not principally, but at least take into account the broadly speaking, strategic aspects of this. I mean, the Chinese, I don't doubt it, inadvertently allowed this new virus to escape. And they did nothing at all to warn the world of what was coming or to restrain the spread of it from China, though they certainly were very authoritarian in trying to fight it within China. And as a result of it, the Western world shut down for a year and yielded up to China. We've suffered a terrible strategic defeat in the West. And in addition, I think there's been, unintentionally, I'm sure, a considerable movement to incite fear and a generally fearful attitude to public health that is beyond what was justified. And I think we have to reverse that. Of course, we have to take care of the most vulnerable. Of course, Dr. Saul was right that we should have moved differently than we did to isolate and protect the most vulnerable. Our percentages of casualties in the homes for the elderly and amongst the elderly are scandalous, and they're quite bad competitively. And so we made mistakes, we all do. It was relatively an unprecedented thing. If there was any precedent, it was 100 years ago, as has been stated. So there's no point in recriminations of what was done up to now, but in my opinion now, I think there's one aspect which is we should essentially abandon these controls and rely upon the level of vaccination and the Omicron instance for immunity. And then the other is a point Dr. Saul raises of the adequacy of our medical system generally. We're rationing healthcare now, even without a pandemic or an endemic condition in this illness, but addressing the problems with our healthcare instead of conducting a national celebration that never ends, that we ostensibly have a more humane system than the United States, which is maybe true and maybe not, but in any case, not relevant. That's not a healthy thing to do. So by all means, let's fix up our health system, but we needn't engage in the perpetuation of obsolete or erroneous policies in respect of this illness to do that.
All right, there's more after the break. Stay tuned.
People are 5 times more likely to be hospitalized with COVID-19 if they're unvaccinated compared to doubly vaccinated, and they're 10 times more likely to end up in the intensive care unit.
Welcome back. The pandemic upended our lives, so is there anything we can learn from it? Conrad, I'll start with you on that.
Here, I would tend to defer to my professional medical colleagues because I don't know really how much we have learned. But if there's one point I would very tentatively advance, it would be that we have to be careful about, as in my opinion, with the best will in the world, I don't doubt it, our public health authorities did here and in other countries, pronouncing that this is what science says. And the problem we have here, in my opinion, was that the whole issue became tied up in the political campaigns in the United States. And there was a tremendous effort by the media that was hostile to the previous administration to terrorize the American public and invoke the theory that science absolutely unanimously required a massive shutdown in order to produce an economic recession that would be politically helpful to those who were out of power at the time. But and as always, American public attitudes were very influential in the rest of the world, and especially here. But I think to answer it is, I think we just have to be a little more careful as we rush out of the gate in what we do. And we now know that that era when we were warned to clean the surfaces of everything around us, and all these horror stories about droplets and so on. A lot of that was just nonsense. I don't doubt it was advanced in goodwill, but I think we should try and be a little more cautious and less panicky in our responses to these things. And I'm sure that the doctors on the panel would be able to affirm that we have learned a great deal, just as an administrative medical issue, public health issue, how to respond to things of this kind.
Doctors, I'll go to you. Dr. Stahl first.
Yeah, look, I think one thing we have to, and I'd be curious for Dr. Rao to weigh in on this, is, there's no guarantee that successive variants are actually going to, be any milder than Omicron. It's possible that the next variant is a vaccine escape. It's possible it's more transmissible. It's possible it's milder. We don't know what the future holds. I agree with other people on this panel that we cannot continue to live life with restrictions indefinitely, that there are accumulating harms from restrictions, and that we need to evolve the way we live our lives to keep up with science. And yes, there were things that we learned about, that we misapplied things early on that took too long. Aerosol transmission is a good example where I think many of the measures took too long to catch up with the evolving science. But I would caution against giving way to sort of lazy optimism that this is going to be milder. The other assumption that I would be curious for Dr. Rao to weigh in on is that that immunity from Omicron is going to protect and is going to be durable, specifically from acquired infection to protect months in the future. So that being said, we cannot live with these restrictions. We can apply the mismanagement and the lessons we learn, and I think that centers around a few things. One of them is to use the tools that we know that we have and that we still are not using as effectively and efficiently. And that's the ability to test, and that's the ability for people to be able to manage the disease with antiviral therapies now at home to try and prevent them from coming into the hospitals. I still think there's a lot of work we can do to increase vaccination rates. I know I may disagree with Dr. Rao on this, but I think there's both ways to do this through thoughtful community outreach, which I think he will agree with, but there's good evidence that mandates have worked. In Ontario, implementing the vaccine certificate increased rates of vaccination by about 12%, and that's been replicated in many provinces and across the world. And also, to Conrad's point, what are we doing to rebuild our healthcare system in a way that can accommodate future pandemics in a much more effective way?
One thing that is getting clearer is that people who have been infected previously, if they see a new strain, this has been shown very well in Qatar, and it's also been shown in the UK, they do not have serious outcomes. They are not the ones who are flooding the ICU, even if they're unvaccinated. That was shown beautifully in an MMWR last week from California's data, that people who have been previously infected have a durable protection. The ideal is to have a hybrid of immunity where you get vaccinated and then you see Omicron, then you're super boosted, or you're me with 3 doses of vaccine and you got Omicron. So that would be the ideal, but the durability of immunity is one of the big challenges with this disease. And the durability of vaccine immunity is starting to show itself to be poorer than the durability of natural immunity. However, if you've just gotten the vaccine, you're better off than someone who had the infection a year ago in terms of protection. So we've got a very interesting situation where boosting a certain group of people and maintaining healthcare capacity that way may be wiser. Dr. Stahl mentioned the idea that vaccine rates went up with vaccine mandates, but the question is not just the rates going up, who got it? If we increased our vaccine uptake rates in people between 14 and 29 years of age, that didn't affect healthcare capacity or healthcare strain. Those people don't end up in the ICU. If it affected people who are 60 or 70 years old with multiple comorbidities, diabetes, obese, and they're working in a factory, in a closed setting, getting multiple exposures to the virus, especially during Delta, that's a great return on investment. And you could argue that having coerced them might have achieved something. But this is a blanket approach where one size fits all with these mandates. And we're doing it even now after our own prime minister got the disease despite being triple vaxxed and having probably the best physical distancing program in the world, a security detail.
The one thing I just wanted to follow up on is, the fact that our prime minister got COVID-19, it was also the fact that the next day he was able to stand up and give a press conference to the country, right? So, getting infected is not the mark of failure of vaccination. It's the mark that we're not going to have sterilizing immunity. But the fact is, if you look at Ontario data, and this has been replicated elsewhere, people are 5 times more likely to be hospitalized with COVID-19 if they're unvaccinated compared to doubly vaccinated, and they're 10 times more likely to end up in the intensive care unit. So, those pie charts or what we talk about the base rate fallacy of referring to most of the people in our hospitals being vaccinated with COVID-19 is disingenuous because it doesn't look at the individual risk of being unvaccinated, which is markedly higher when it comes to healthcare utilization as compared to the vaccinated population.
So they definitely create more strain if they're unvaccinated and they're infected and if they have high risk conditions, no question. I'm not applauding them, but as a contributor to the whole healthcare system strain problem, I think we have to be proportionate in terms of ascribing blame to them. And when you're talking about truckers who are otherwise healthy, if they don't get the vaccine, yes, they may be infected, as you said, just as the prime minister was, but I don't think they're going to contribute to an ICU stay or ICU surge. And if we believe that vaccination stops transmission, that used to be the old argument. If they get the vaccine, they'll actually save the healthcare system by preventing transmission. I think we know that's not true after about 10 weeks of it transpired after you get the vaccine. So as a healthcare worker, I got the 3rd dose thinking I would protect my patients by having the booster immunity, and with Omicron circulating, I would protect my patients. Turns out I ended up getting the virus when I wasn't working, so it didn't work, but maybe there was a lower chance I would get it.
All right, stick around. We'll be right back.
You will probably find in 20 years' time, maybe more, is that mental health is going to be a very big thing for all of us.
Welcome back. It's been said that the longer the global effort to stymie the pandemic through lockdown continues, the less likely we are to re-emerge into a world that we recognize. So what comes next, and what will be the legacy of COVID? I'll go to you first, Aditi. We've noticed changes in all avenues, the most obvious being the physical change associated with the face mask. Now, many parts of Asia have made masks a routine accessory for anyone feeling a little bit under the weather or just looking to avoid the seasonal flu. And I think it's easy to imagine how that behavior could be adopted here. What do you think?
That might happen. I wouldn't be able to say that at all, how those behaviors continue, but I can look at certain diseases, pandemic rather, has changed our behavior in the past. The sanitation, for example, we got more conscious of sanitation methods, cleanliness, because we had cholera, and that actually changed city planning. So much of that work has gone because of cholera. And so each disease will change our behavior. It does alter our behavior to some extent. And for example, the idea of tuberculosis, the big legacy of tuberculosis is that you had in the later phase, the first phase is the romantic phase where they thought it's a good thing to get tuberculosis because it was the whole romantic notion of better for the spirit. But once they realized it's contagious, the big thing was going into these health resorts and health cures. And so everything has a behavioral change, how we go and think, okay, now for my health, I need to go to a retreat resort, take a break. That legacy is very much connected to tuberculosis. The only thing that I think, and the only predictions I can make, you will probably find in 20 years' time, maybe more, is that mental health is going to be a very big thing for all of us.
Dr. Stahl, that is one area that on which we don't have much prior data, and that's how pandemics have affected mental health. To Aditi's point, we know that it did, but the extent may not be known. Do you think this is one area that we learn from?
I think it certainly is an area we learn from and will only continue to learn from. We have some initial data about, for example, opioid overdoses that have skyrocketed during the pandemic for a number of reasons, mental health concerns, but also lack of ability to access services, and also border closures resulting in a more adulterated supply of opioids that has resulted in death. So yes, absolutely. Mental health coming out of this, we will need to repair the harms that have been accumulated. We will have a catch up of services. And the other population that I think has been tremendously impacted are healthcare workers and frontline workers that have experienced severe burnout, have experienced loss themselves, have been asked to carry a lot of the burden of this pandemic. And we will need to invest in repairing their mental health and the impacts of what COVID has had on them as well.
I will make a fashion point on the start of this segment, the question about whether masks will catch on. I boldly state that masks will not make it as a sartorial fashion in the Western world.
Dr. Rao, last word to you on this one.
Well, one thing I worry about is the impact of having had conflicting messages and what some of the behavioral sciences people call cognitive dissonance, where it's sunny today and it's raining tomorrow. Masks are not needed. Oh, now they're needed. It's not airborne. Oh, yes, now it is airborne. Actually, we're going to open schools if we reach something. Oh, no, we're not going to. There's been a lot of whipsaw policy making, and I fear that the faith in public health messaging will be lost because people are sometimes making bad decisions not to be vaccinated. I mean, people make bad decisions all the time. I still care for them. But you wish people would listen to public health advice through power of persuasion. And if there's a lot of inconsistent messaging, as we have seen here, I think the faith in public health messaging will be eroded in future challenges. And some studies have shown that this is entrenching certain people's views and that they even think childhood immunizations for their kids aren't a good idea.
All right, we'll be right back with more of the Zoomer. Welcome back to the Zoomer. It's time for final thoughts from our panelists. So we will start with Dr. Rao. Go ahead.
So as we surf to glory on the downside of the epidemic curve of Omicron as it continues to fall, we need to have a discussion. What will we do with the next variant, with the next surge? What are we not going to do in terms of restrictions that we did this time? What are our strategies going to be for communications so that we don't confuse people in future? That's my hope for the future anyway.
Dr. Stahl?
Yeah, I think we have to recognize that the post-Omicron future still is uncertain, and that each time that as a society we have tried to play chicken with the virus or tried to balance things without a complete and robust plan, that we have been burned, and ultimately it has resulted many times in harsher, more severe, and more prolonged restrictions. So I think moving forward, we all have a collective goal to return to normalcy, and we all have a collective goal to protect the well-being of ourselves and of our fellow citizens and people we live with, especially vulnerable amongst us. So let's have a plan that doesn't just rely on, as I referred to before, lazy optimism. Let's still plan to increase vaccination rates through multiple tools that we have available. Let's plan to have good surveillance and testing and therapeutics for individuals. And finally, as Dr. Rao and as others have talked about, let's rebuild our public health and our healthcare systems, and let's try and reinvigorate the trust that we need to have in public institutions like public health and government, so that messaging is clearer and so that we have more of a sense of solidarity moving forward so that we can combat this.
Aditi?
Well, I'm hoping there will be more courses in education on history of pandemics. There is a lot to learn. I was teaching this in 2018, from 2018, and I taught it as the pandemic was happening on the timeline. So it was a unique experience. We were doing history, and so much of our behavior is just a reflection of history. We had a quiz in class, I remember, plague or COVID, and nobody was scoring 100%. Our behaviors don't change. And I hope there will be more courses and more awareness of how pandemics have shaped history. There is a lot, but there has to be way more that it has changed. And there has to be way more of that education and awareness of historical context of pandemics, certainly.
And finally, Conrad.
I agree with what all of the previous speakers have said, but I would just add that I think we have to put in place, if we can, an agreed consensus that we have to be more careful about allowing, broadly speaking, emotional arguments to prevail over others. I believe Dr. Saul made the point that throughout the heavy preoccupation of the health system with this pandemic, a great many people suffered very damaging delays in serious necessary procedures. And we have to balance that. And we have to balance the functioning of the economy, the economic well-doing of vulnerable people against more intensive applications of countermeasures to a pandemic without anyone raising the point, being accused of monetizing life and being cold-hearted and completely materialistic and having absolutely no human qualities at all. If we could get a consensus in place about giving a weighting to the different factors that are automatically brought in such a crisis as this, which in one way or another affects everybody, then I think we'd start a long way ahead of where we were. As has been said, the only real model we had was 100 years ago. And at that time, it was completely obscured by the fact that everyone was so thankful that World War I had ended. So certainly there's a lot to learn from this. And we can start certainly, with what's been said here.
All right, we'll have to leave it there. A big thank you to all my panelists for being here and for sharing your expertise, and for you at home watching. As always, thank you for being with us. We'll see you next time.